Hello, everybody, and welcome to Home of Medicine podcast. My name is Ben Lovell, and I'm a consultant in acute medicine working in London. And I'm here with my colleague and co-podcaster, Amy.
Hi, I'm Dr. Amy Burbridge. Nice to be back, as always, Ben.
So it's my turn today, and I've got a case for you. And it's a case of a patient who I saw on the acute medical take, which is my favourite place in the world, in A&E Resus, which is my favourite place within the emergency department. So this is a referral to medicine, a 48-year-old woman with no significant past medical history. And she presented to hospital with actually an insidious sort of 3-month history of shortness of breath with a dry cough. And she felt unwell, increasingly unwell over the last 3 months, and especially the last 2 weeks. And today the cough was so bad and she felt very breathless. So she decided to come to be checked out in the emergency department. And she'd lost a bit of weight over the last 3 months as well associated with this. The last 7 days have been really rough for her. She describes herself as pretty tough and sort of hospital averse, and she really tried to cope at home. But she'd had a real worsening of the breathlessness, much reduced exercise tolerance, so simply 100 meters for having to stop and pant and get her breath back. And normally she had unlimited exercise tolerance. And she's just completely off her food, no appetite, not eating and drinking at all. And that was her presentation, really. She didn't, no other symptoms of note. Any first thoughts?
So the first question I want to ask is, why were you in resus with the patient?
She'd been moved to resus because she apparently had enough features to flag up for query sepsis and was moved into it by the ED team. So we'll find out in a bit, but her observation showed a hypoxia, a tachycardia, and a slightly saggy blood pressure. So that's why she was in the resus.
Okay, excellent. So 48-year-old female, 3-month history of shortness of breath, cough, breathlessness, reduced exercise tolerance. Did she say that she'd lost some weight?
Yes.
Yeah. Okay.
Yeah.
Do you know how much?
It was about 3 or 4 kilos, enough for her to notice, but not a huge amount of weight loss.
Okay, and she'd lost her appetite as well. Okay, so there could be many things going on here. There could be one diagnosis, there could be more than one diagnosis. So the first thing that comes into my head is this cancer? Is this malignancy? The weight loss, the decreased appetite, the feeling unwell. My mind just goes straight to malignancy, and I think that's my primary diagnosis that I need to make sure that she doesn't have. However, you said that she's also acutely unwell, so my acute brain is thinking, is this sepsis, shortness of breath, cough? I'm also thinking, could this be a blood clot? Could it be a pulmonary embolism? Could it be multiple pulmonary embolisms? Could this be an autoimmune lung disease? Could this be, I'm really thinking a bit strange now, to be honest, could this be a vasculitis that's causing lung disease? Could this be cardiac failure? I know she's only 48, but she's short of breath. Exercise tolerance is down, but she'd lost weight. And I guess if I'm thinking cardiac failure, she may be retaining fluid, and sometimes people notice that they gain weight. So I'd want to find a little bit more about cardiac conditions. So is this a respiratory cause of shortness of breath and cough? Is it a cardiac cause? Is it an autoimmune cause, or is it something like a malignancy? That's where my mind is at the moment.
Okay, so really wide differential there, covering several body systems.
Very wide, absolutely. Yeah.
That's fine. You can going into a scenario with an open mind, as long as we gently close it as this, as the history develops. So just to give you a bit more information, she was very, very short of breath, no chest pain, no preceding symptoms such as a nasty virus, which set this all off, for example. And she had a very dry cough. She wasn't bringing up sputum, but it was a hacking dry cough, the kind of cough you can hear from the other end of the department, coughing like crazy. And she was, her respiratory rate was quite elevated, actually. And she was normally incredibly fit and well. She had no past medical history of note. She wasn't taking any regular medications. She did not smoke. She drank alcohol socially, maybe once or twice a week. She worked in interior design. And I went to have a look at her in resus, and end of bedrogram, she didn't look very well. She looked clammy. She looked sick. She looked miserable. Her saturations as she walked in the door were 92% on air, so she'd been placed on oxygen, and they'd corrected quite nicely with 4 litres of oxygen via nasal cannulae. Examined her chest, no crackles, no wheeze, no added sounds at all. And I had a look all over. Her calves were slim. There was no retained fluid. There was no signs of a peripheral DVT, but she was tacky. Her heart rate was 122 sinus rhythm. Blood pressure was 102 over 67. And her temperature was 36.9. So she was afebrile. Her heart sounds were normal for what it's worth. And I couldn't really elicit any other signs on physical examination. So, what do you think about that?
So just to clarify, her chest examination was completely normal.
Chest was normal, yes.
Ooh, okay, but she's hypoxic, tachycardic, and hypotensive.
Yeah.
So could this may be infection? I mean, I know her temperature's low, but it could be infection. She could be immunocompromised. It could be a pulmonary embolism, potentially, because of the tachycardia and the hypotension and the clear chest. Often you don't find anything on examination of the chest in a PE. It's sort of my differential included cardiac failure, and there was no pedal edema, and the chest was clear. JVP.
Was not elevated.
Okay, so I sort of clinically that's going against that. Did she complain of orthopnea or any paroxysmal nocturnal dyspnea?
She didn't describe that at all. She said her shortness of breath was pretty much constant and she was coughing a lot, but she didn't say worse at night, worse laying down.
Has she had COVID sort of 3 to 4 months ago before this all
Not
started?
that she knows of. And that's why I said
Mm,
to her, did you have a nasty viral
mm,
infection that set all this off at the beginning? Because I do sometimes wonder about that, whether someone had COVID and then they got super added bacterial infection and things after that, we did see in the big COVID waves of 2000, we
mm.
saw a lot of venous thromboembolism, so a lot of
Absolutely.
PEs. But no, she had never tested.
Okay. It could still be malignancy, potentially,
Mhm.
because of the chronicity of it over 3 months. It could be another type of infection, so TB, potentially. Could this be pneumocystis? Because sometimes with pneumocystis, you get the hypoxia, but you don't necessarily get any findings on auscultation of the chest, potentially. I'd like to do a HIV test just to make sure that she's not immunocompromised from HIV. Does she take any medication that could be causing lung damage?
Like what?
I'm thinking
Oh,
amiodarone.
you mean like amiodarone,
Yeah. Oh,
nitroglycerin, lung fibrosis? No, no, nothing like that.
okay, so she hasn't got lung fibrosis. Okay, and to be fair, if she had lung fibrosis, she'd hear that probably hear that on auscultation anyway, wouldn't you? So this is a tricky one. Could
I'll
it be?
tell you that there was a chest X-ray which was really clear. A tiny rim of fluid was the only thing. Well, no, not even a tiny little blunting of the diaphragm we noticed, which indicated a tiny effusion, which is at the left base. But otherwise, the chest X-ray looked clear. Now, ED had looked at the patient. They've said hypoxia, normal chest X-ray, normal chest exam, tachycardic. We need to screen for a PE, and they'd actually requested a CTPA. Hadn't happened at the time I came to see her yet, but that was in the pipeline. And would you like some blood tests?
Yes, but also one question: did you consider POCUS in this case?
Oh, Amy, you've seen my notes. Yes, I did.
Oh, I haven't seen them.
I'm good. I know. Well, no, that's because we're hundreds of miles away from each other. But that's an excellent. What focus of what?
POCUS of the lungs, because
Why?
so chest X-rays don't show huge amounts of the lungs. So I guess you're probably going to be looking at 50 to 75% of the lungs. So what about the lungs that we can't see from this two-dimensional image, but actually we need 3D images such as POCUS. So I am a massive fan of POCUS now, having been trained in its use sort of the last few years, particularly in the lungs, because you can identify. Now, a normal chest X-ray, you put a probe on, you're like, oh my God, there's fluid. Oh my God, there's those jellyfish that are wobbling around that indicate infection. There are so many things that you can see. There are B lines on there that can indicate that there could be fluid that you just don't see on a chest X-ray. And it can be so, so important.
Well, yes, you've convinced me. I'm just adding in because we were in our last, no, 2 episodes ago, I think we were in Florence at a live conference doing a really brilliant session at the European Federation of Internal Medicine. One of the feedbacks we got from our international listeners was sometimes we talk very fast and we use a lot of UK acronyms that they just struggle to follow in their second language. So we're talking about POCUS, which is point of care ultrasound, bedside ultrasound testing, which has had a massive explosion in understanding training, especially in acute medicine, which is now a mandated part of the acute medicine curriculum because it is an incredibly powerful diagnostic tool, as you say, at the bedside for realistic sort of in-time diagnostic intervention. So we did do POC. I didn't do it. I'm so sorry. I'm not trained. And I wonder if I'm too old to learn new tricks, but the new generation are.
I'm going to stop you there, Ben, because I've
Yeah.
just learned how to do point of care ultrasound in the last 2 years.
Will you
So
teach me?
it's been hard, like it's been really difficult, but I've had a brilliant teacher. We have a POCUS fellow working with us, Chris, who's an F2. I mean, his knowledge is phenomenal, and his enthusiasm and passion for POCUS has sort of passed on to me. So I now feel confident with lung DVTs, abdomens, sort of the brief bits of abdomen. But I mean, I'm not going to be learning how to do echoes because I just think that's probably past me. But we're never too old, Ben.
I actually do know how to echo because I learned it when I
Oh,
was an ST3 in cardiology, when I was doing my cardiology rotation
yeah.
of acute medicine. But lung ultrasound, I just see white blotches on the screen. Okay, it's on my long list of things to conquer in my
Excellent.
maybe my next appraisal. So anyway, my patient. So the acute medicine registrar who was on call with me, who is the future of acute medicine and therefore is POCUS trained, came and did some POCUS and actually found on the left posterior dense consolidation of the lung.
Mm.
And I'll tell you that the blood results showed a CRP of 270. So where are you now mentally with this patient?
So, dense consolidation, CRP 200. This is infection until proven otherwise, in my mind. And given the hypoxia and the tachycardia, the dense consolidation, the hypotension, what was the respiratory rate, by the way, and the
Was
lactate?
Oh, the lactate was 1.8 and the respiratory rate was about 2022.
Okay, so I would actually treat this as sepsis.
Mhm.
Um, I know, I know that the lactate's okay, but actually, you don't necessarily have to have a high lactate for this to be sepsis. So I would treat with oxygen, IV antibiotics, IV
Yeah,
fluids,
yeah,
and very closely monitor.
yeah.
If there was not much improvement, i.e., urine output wasn't great, blood pressure stayed low, heart rate stayed high, I would also consider contacting critical care and getting some support if needed.
Okay. So you're treating this as a community-acquired pneumonia and
Yeah,
sepsis secondary to that. Okay.
at
So
this point, yes,
yeah.
at this moment in time, yeah.
So cancel the CTPA then because we don't need it.
No, no, I wouldn't. So she could still have a PE because patients, as Hickham's dictum, patients can have as many diseases as they damn well pleases. It's a tricky one.
But the
We
POCUS is POCUS ultra is meant to be a nice non-ionizing
it is.
radiation way of making a diagnosis that sort of obviates the need to get cross-sectional imaging and ionize patients. And an argument would be we have made the diagnosis now using our clinical acumen and POCUS. Why go?
Mm,
Why keep testing? Because the CTP was requested at a different point in the patient's journey when the number one was PE, but now the number one is quite definitely pneumonia. We've seen the consolidation. Um, I guess you can always say, I think she's got pneumonia and a PE.
exactly. She could do.
I've seen it. I've seen
Yeah,
that.
absolutely.
Yeah, and it's quite tricky sometimes to work that out because they both present very similarly. Hypoxia, the existence of pleuritic pain doesn't necessarily point just towards PE because you can get really nasty pleuritic pain with pneumonia as well. So it can be quite difficult to tease out. But the porters are going to come to take it to the CT scan. Yes or no, CTPA?
Oh gosh. So I've got a diagnosis in front of me. Oh, oh gosh, I am going to do the PE, the CTPA. Now, it's a really difficult one because I'm now starting to think, okay, has she got a huge PE and she's infarcted? And if the consolidation is infarcted tissue that we can see, she hasn't got a temperature because this isn't infection, it's just blood and necrosed tissue from this massive PE that she'd had. So I'm starting to now really worry that this is a PE. um,
But if ED hadn't have arranged the CTPA,
I
would you
would
now be requesting one?
no, I
So it's
wouldn't.
the fact that it's already been requested is making you want it, I think. Is that it? That it's already been organized. So you're
It,
just not cancelling it rather than actually requesting one. I'm just really interested to know what's influencing the thinking.
the fact that it's already been requested means that somebody else has already thought of this. So have they thought of it, of a PE, and have I not thought of it? So does that mean that their
Okay.
thinking is different to mine, and who's to say that mine is right and theirs isn't?
But they thought of it because they hadn't got the poker showing consolidation. They were looking at a clear chest x-ray.
That's correct. I'm also thinking if I don't do the CTPA and she doesn't get better and she has a massive PE, then 4 days down the line, they'll say, well, why did you cancel it? We requested a CTPA. Why did you cancel it? I thought it was a PE. I don't know. I am genuinely thinking about this on as I'm now, and I
I'm like that it's not an easy one for you because I don't think there is an easy one, because I think it's a nice insight as well into it is so much easier in many scenarios in medicine
mm,
to look at the path of least resistance. To cancel
judgement.
the CTPA requires getting through to someone and doing something, whereas letting it happen, I don't have to do anything. And if I imagine I'm in an incredibly busy unit with a lot of demands on my time,
Yeah.
if someone said, "Do you want to call and cancel that CTPA?" then I'm not saying that we should do unnecessary tests for patients because we're too busy, but it might influence what I do. I
Mm,
might talk myself into saying, but we'll do it actually. And I can think of a justification for that now to make that fit. And I'm sure that drives us. Also, it takes a lot of gall sometimes to undo someone else's plan.
yeah.
um, I find that when I see people on the acute medicine unit, and if I want to go against maybe what the post-taking consultant wanted to do
Mm, really
yesterday, that's my
hard.
colleague, my consultant
Yeah.
colleague, I even find it tricky sometimes if the doctor, the resident doctor, the reg or the SHO, what have you, is presenting a patient to me to post-take, and they'll say something on the lines of, "Oh, and I also they had a couple of troponin come back, which were not very elevated. I think we could ignore those. So I've not done anything anyway." I'm more likely to go, yeah, that sounds reasonable, rather go, hang on, whoa, slow down. Well, what do you mean a bit elevated? Just go through that bit with me, because you can get swept along by
Exactly.
um, someone else's thinking, especially if someone that you know, you trust, you respect, they make intelligent decisions, and what the impact is on your workload and your cognitive load at the same time as well.
So the answer to your question, would I do a CTPA or not, isn't as simple as yes or no. All of these things that you've just described are going on in our heads.
Hmm.
Um, and another option, I mean, I've been asked this question many times, probably most days when I'm at work. And should I cancel it then? Should we do this? And I'm just like, oh, just cancel it. It's absolutely fine. No problem. Cancel it. And a couple of times I've said to cancel it, and the person's disagreed with me. They've done it anyway.
Yeah.
It's fine. That's absolutely, that's no problem. And I go back and say, well, I just noticed that I'd asked you to cancel that CTPA, but you did it anyway. I just wondered why.
Yeah.
And so again, it's really important to understand that. But another option would be to say, actually, we don't need the CTPA now. Let's treat this lady with the antibiotics and the oxygen. If she doesn't get better, then we could, or she gets worse, then we could consider doing a CTPA because
Yeah.
we could be a PE potentially.
Yeah. It's not never do one. It's just don't do it right now, because I think we've got enough to go on.
Mm-hmm. Yeah.
So you want to know what I did?
Go on.
So they asked me the question, "Do you still want the CTPA they've requested?" My response was, "No. Why would I want it? You've just told me there's consolidation and she's got pneumonia. Treat as pneumonia. That's fine." And I assumed the CTA had been cancelled. In fact, it wasn't, because they were so efficient in the radiology department. They came down and whisked the patient off for a CTPA quite quickly before my team had a chance to cancel it. So she actually
Mm.
had the CTPA, even though I said, "Please don't do one."
Yeah.
CTPA result was dense collapse of the left lower lobe secondary to a left posterior mediastinum tumor compressing the left lower lobe bronchus, no pulmonary embolism, but enlarged mediastinal lymph nodes could be in keeping with diagnosis of lymphoma.
Oh gosh.
And that's a scan I didn't want.
Wow.
So where do we put this in our brains? What has happened here? Is it a good thing that's happened, or a bad thing that's happened? And how do we justify all of this and sort of make sense of it all within the framework of clinical reasoning and diagnosis?
I mean, I guess we have just alluded to all the reasons why we would and wouldn't do it. I mean, she wouldn't have got better. So if you hadn't have done the scan,
Mm,
she wouldn't have got better. We know that. And she may have continued to lose more weight, become more breathless, reduce exercise tolerance and appetite. So she would have had a CT at some point, which would have picked this up potentially.
mhm.
However, the CT scan was done, and that sometimes happens in medicine, and that's life. And we found a diagnosis, and great for the patient. And what can we learn from that?
Yeah, that's what I want to know. What can I learn from that to grow and develop continually as a healthcare professional? Because I'm not done yet. I'm still learning. I'm still developing professionally. And do I, one way of looking at it is how lucky for the patient that they didn't cancel the scan that I said to cancel. You're right. I think it would have been picked up eventually, but it would have been a bit delayed, right? The diagnosis would have been a bit further down the road. But on the other hand, I can't CTP every single case of pneumonia comes in case one of them has got a lurking lymphoma underneath it.
But this case was different because she'd been unwell for 3 months.
Yeah.
So let's say if we reframe it, and if I saw a patient in A&E resus tomorrow who had a history of 3 days of shortness of breath, cough, pyrexia, I wouldn't necessarily do a CT on that individual. However, if we go back to the history, the diagnosis was in the history, not necessarily of lymphoma, but about being more chronically unwell. 3 months of being unwell,
Mm,
losing weight, decreased
mm,
appetite. You
yeah.
said that she looked really unwell, that
Yeah.
didn't necessarily fit with the just pneumonia. So if we go back to the beginning and say, well, actually, and you even said she didn't look well, would that fit with a 48-year-old with pneumonia, or is there something else going on?
I think that's key, actually. I think it's the preceding several months
Mm,
of systemic
exactly.
symptoms, systemic unwellness.
Yeah,
Yeah.
I think
So
that's what it is.
that's what I've taken away from the case, really. And it's like you said, patients can have, you said right at the beginning, as many diseases as they like when they
Yeah.
come in. And there is in clinical reasoning, there's something called premature closure, which is when you stop early,
Yeah.
and you stop thinking. And maybe that's what I was guilty of there, a bit of premature closure and not saying, okay, but what else?
Hmm. It's also confirmation bias, isn't it? Where you've took a history, you think it's pneumonia, you confirm the diagnosis with the POCA scan, it had consolidation, you have the CRP and the tachycardia, you've confirmed the diagnosis. I don't need to look for anything else now because I've got the diagnosis there.
Yeah,
However, what you don't want to do is to have hindsight bias now, where every patient you see who has shortness of breath and a cough, you go, well, I missed a lymphoma, or I could have missed a lymphoma. So therefore, I need to check every patient for lymphoma.
yeah.
So I guess it's a balancing act, isn't it?
Well, no doubt I'll be more sensitized now to the possibility
Yeah, yeah.
in the history taking.
But this also raises a really important question about the validity of chest X-rays.
Mm,
So the CT findings were significant: highly lymphadenopathy, collapse, consolidation, and a dense consolidation. The chest X-ray looked normal.
yeah.
Should we be doing chest X-rays? Should every patient have a
Everyone gets one.
yeah? But and if you have a normal chest X-ray, does that mean that there's nothing wrong? I don't know.
Well, not in this case.
Exactly.
So I guess if anything, it's a very supportive case for the development of poker skills.
Yeah, absolutely. Very good case.
Did you like it?
I really liked
Great.
discussing the bias again, and it's
Yeah.
a beautiful case that really we talk about clinical reasoning. And actually, I'm going to say it, I say it every single episode: listen to your patient, they are telling you the diagnosis. And I'm not saying that by listening to this history it would have gone to lymphoma, but by listening with the 3-month weight loss, all that sort of stuff, actually that's something else is going on. we need to latch onto that and find out what that is.
No, I completely agree. Listen to the patient. They're telling you their diagnosis, often hidden within several other
Exactly.
layers.
Yeah. And that's the beauty of clinical medicine and that patient interaction and taking history, because it's all in there. It's all in the communication.
So thanks for analysing that case with me, Amy. So a nice conversation about clinical reasoning and diagnostic anxiety, which was really the heart of what we're trying to do here at Home Medicine. And thank you so much, people, for listening and guessing along. And I hope that you were thinking as well when I was asking Amy the question about would you or would you not continue. You were going yes or no as well, because I think it's more fun if you join in as well. And we're presenting the cases as much as you as much to each other. Thank you so much for listening to Home of Medicine podcast. We have been plodding away at this podcast for years because we love it. And it's sort of slowly growing bit by bit. And if you could help us by going to wherever you listen to it and rating or reviewing or leaving us a comment, and we read every single one, and then we text them to each other and get very excited whenever we get positive feedback. Or you can drop us an email as well. But we love getting feedback that you enjoy the podcast, and maybe you listen to it whilst you're doing your run or on the commute or something like that. And please do tell your friends if you do enjoy it, because we'd love to connect with some more people. Thank you so much, Amy. Great to see you, and I'll see you next time.
Thank you for listening. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.